Today we have a very fascinating topic on fetal alcohol spectrum disorders. Is one of those diagnoses as a fetal medicine specialist. I would really be keen to see what our specialists in the panel have prepared for us, and how we can recognize this disorder, and what is the burden of disease, especially in our country. It's one of those things actually you hardly get to diagnose. So very curious to know about it. So we have two panelists today. We have Dr. Susan Wamithi from Aga Khan University Hospital, a pediatrician with a subspecialty in developmental pediatrics from University of Toronto. And she is very interested in childhood disability and developmental disorders. And you can see alcohol being one of those that will be contributing this right from intrauterine device. Our other panelist is equally a pediatrician with a subspecialty in emergency medicine, currently based in Columbia University. He's also a professor in pediatrics and nutritional epidemiology from Boston University. So we are very excited, Kata and Wamithi, to hear what you guys have for us. So let's begin.
Okay, hello everyone. Thanks so much for having me today. My name's Colin Carter, and as Dr. Ndima explained, I'm a pediatrician at Columbia, and I'm really happy to partake in this seminar. So thank you everyone for inviting me, and I hope it's useful. I'm gonna try to share screen. We didn't get to do a little practice beforehand, so hopefully this works well. Okay, I'm going to assume that you guys can see what I can see. And I'm going to try to keep an eye on the chat, but feel, if the panelists can interrupt me if necessary. Okay, so today we'll talk about the global impact of prenatal alcohol exposure and fetal alcohol spectrum disorders, which is really the umbrella term to talk about the diagnoses of children affected by prenatal alcohol exposure. I have no financial disclosures to report. Most of our research is funded by government grants from the United States National Institutes of Health and grants from South Africa. I'm going to focus on first presenting the global prevalence data of prenatal alcohol exposure and FASD prevalence. Then we'll talk about dose response patterns of the teratogenic effects of alcohol. I'd like to spend some time talking about prevention efforts and then also some high-risk groups at the end, time permitting. So FASD are the most common preventable cause of developmental delay worldwide. And I always pause when I say this because I think where malnutrition fits into that is probably debatable. But, it's certainly one of the most common preventable causes of developmental delay in children. In the States, we see this in about 2 to 5% of children, but it's far under-recognized. If you ask most pediatricians what the prevalence is, they're shocked when you give them this number. And for full FAS, which I'll talk a bit about, which is the most severe form, we have about 2 to 3 cases per 1,000 live births. This is more common than diseases that get a lot of attention in the medical community, such as cystic fibrosis, and it's comparable to autism, although the deficits in children with FASD are usually not as severe as children with autism. A lot of my work focuses on South Africa, where the prevalence of FASD is up to 20 to 30% in some communities. And currently, the only prevention methods are really behavioral interventions aimed at reducing exposure and reducing mothers drinking. Sorry. Okay. So the FASD phenotype will be discussed more by Dr. Wamithi, but basically the characteristics are pre and postnatal growth restriction, as well as a characteristic facial dysmorphology. But there have been reports of damage to every organ system, and the ones that we focus on the most are the structural brain abnormalities, including smaller total volume and regional damage, as well as neurocognitive deficits in social learning, executive function, memory, visual spatial learning, and math skills. And I think what this kind of summatively affects is children who become adults who are really have trouble engaging with society. So they have trouble keeping jobs. They're often caught in the criminal justice system. In South Africa, we see them engaging in a lot of risky behaviors, including drug use and gang violence, which is really, so when you think about the diminished potential here in the population, it's really quite devastating, especially considering that this should be preventable. So I'm going to give you some data from a pretty well done systematic review and meta-analysis published in The Lancet, where they looked to estimate the global and regional prevalences of alcohol use during pregnancy. And so they found about 330 studies to provide data for that, and the prevalence of FAS, which again is the most severe form of fetal alcohol syndrome. And they found about 62 studies to support those conclusions. In this study, alcohol use is binary, so they didn't distinguish between chronic low-level drinking and episodic binge drinking. Binge drinking meaning like having 4 or more drinks per occasion, which is considered the most risky drinking, and about the level of drinking that makes someone feel, drunk, for lack of a more specific term. And we just keep in mind, and I'll talk a bit more about this, for every one child with full fetal alcohol syndrome, which is the focus of this study, there are many more children who are affected. So on this map, you can see the global prevalence of alcohol use during pregnancy. It varies widely in areas where religious practices prohibit alcohol. Of course, you see less alcohol use, but most of the world has a significant number of women drinking during pregnancy. And I tried to zoom in here on the Kenya region and East Africa. And you can see for Kenya, it's estimated around 10 to 15% of women are drinking some alcohol during pregnancy. Your neighbor in Tanzania has a bit higher at 15 to 25%. And just going back, in South Africa, it's much higher where I work, which, they're guessing upwards of 50%. So there's a lot of variability there. And like, as I mentioned, if you think about the iceberg of FASD, FAS is like the most visible above the ocean, particularly because the children have a characteristic facial dysmorphology and are more severely affected, so they're more likely to be brought to medical attention. But the bottom of the iceberg is children with partial FAS, and then a much, much larger group of children with alcohol-related neurodevelopmental disorders. So these are children with developmental disabilities or neurocognitive deficits who don't have the characteristic facial dysmorphology, and so often go undetected, and therefore are lacking the services and interventions that are needed. So given that this iceberg idea, that study I just mentioned that was published in the Lancet, it wasn't criticized, but people then said, we really need a better estimate of the prevalence of FASD worldwide. And so they did another systematic review and meta-analysis, again from the same group, published in JAMA Pediatrics. And here you see really the same map, but focusing on the prevalence of FASD. And so these are the number of children per 1,000 in the population with FASD. And so again, I'll focus on, sorry, it's a little blurry, but in East Africa, you can see for Kenya, this is about 5 to 7.5 children per 1,000, so just under 1%. And Tanzania, it's getting closer to 1%. And then again, in South Africa, where I work, you can see it's greater than 20%, which is really just staggering. And the United States is somewhere in between. So the summary statistics here, and I hope these are shocking to everyone, but I'm also always a little bit sad that people are so surprised because the awareness just isn't there globally. But, the global prevalence of alcohol use during pregnancy is estimated to be at, I'm sorry, I'm having a little technical difficulty here, 9.8%. The global prevalence of FAS in the general population is around 7.7 per 1,000 people, 10,000 people. And then the global prevalence of, sorry, this is meant to say FASD in the general population is 1.5 per 1,000 people. And the authors of both of those studies put together these statistics in kind of a global estimate of 1 in 67 women who consumes alcohol during pregnancy will deliver a child with FAS, which translates to about 119,000 children born with FAS in the world every year. And again, thinking about the iceberg, those are just the children at the tip of the iceberg. You can extrapolate that it's much bigger than that when we consider all of the spectrum of fetal alcohol spectrum disorders. So now I'll switch gears a bit and talk about what level of prenatal alcohol exposure is risky. And so I was really lucky enough to be part of this large study where a group of investigators in the United States pooled their data from 6 prospective longitudinal birth cohorts, all in urban and peri-urban settings. And so these were kind of the hallmark prospective birth cohorts that really established the dangers of prenatal alcohol exposure in the 1980s and 90s in the United States. And the groups got together and they used advanced meta-analytic techniques to combine their data. Most of these cohorts had moderate exposure levels across the bulk of the women, although each cohort had kind of a small group of women who were drinking at very high levels. And in these methods, they tried to adjust for potential socio-environmental confounding. And I won't get in too much into the details, but sorry about that. They looked at all of these observed neurocognitive outcomes. They grouped them into baskets of learning and memory, executive function, arithmetic, and reading, which are all areas that are heavily affected by prenatal alcohol exposure. And together they got a composite cognitive function score from each cohort. And they used that as the outcome for the data I'm about to show you. And so the expected result here is what's commonly referred to in teratology or toxicology called a hockey stick, where people expected that above a certain threshold, you'd have a linear effect of alcohol on development, and then above a certain threshold, that would kind of flatten out because at a point that you can't do any more brain damage. But I think what people were really expecting is there'd be kind of this, and I hope everyone can see my arrow here, but down towards the bottom left of the curve, there would be this area where it looks like much safer before the effects of alcohol kind of take off. And that wasn't what we saw. So we saw across the full range of exposure. So the x-axis here is the average ounces of absolute alcohol consumed per day during pregnancy. And the y-axis is the child's cognition score. And this was centered on 0. As you can see, like fully from very high levels of exposure down to almost to no exposure, you have a really straight line here. So it really confirmed what we've commonly said as physicians and healthcare practitioners, that there's no safe level of drinking alcohol during pregnancy. But what was also interesting was we were able to look, because of the large sample size with the multiple cohorts, we're able to look at a bivariate exposure model. So modeling not just average ounces of absolute alcohol per day across pregnancy, but also thinking about drinks per occasion and drinking frequency. And so what you have here is on the y-axis is the ounces of alcohol per occasion. So a binge drink is around 3.5 here. Between 1.7 and 3.5 is a binge episode. And what you have on the y-axis, again, is the cognitive function score. And then the lines here are, the green line is women drinking less than 2 days a month. The red line is women drinking 2 days per month to less than 2 days per week. And the blue line is the women drinking more, or 2 days per week or more. And what you see is as you increase frequency, the effects of dose per occasion get much more stronger. The slope is much more steep. And then kind of flipping that, we can look at drinking frequency days per month on the x-axis, and then we look at the amount per occasion. So it's roughly like less than 1 drink per occasion, 1 to 4 drinks per occasion, and then 4 or more drinks per occasion. And again, you see that as you increase the frequency of drinking per month, as you increase the dose per occasion, then the effect of drinking frequency on cognition gets much sharper or much more severe. And so this really drives home the fact that although there's no safe level of drinking during pregnancy, episodic binge drinking and higher doses per occasion are much more dangerous than, say, chronic low-level drinking. And so what we always say is, like, people used to say like 1 drink per day or more on average is more dangerous during pregnancy, but that's probably not the best message, because there's a really big difference between a woman having 7 drinks on a Friday night versus another woman having 1 drink daily, 7 days a week. And again, I don't know that I would recommend either, but it really does seem like episodic higher level drinking is much worse than chronic drinking. Screening and prevention, I think the biggest take home is that worldwide, the medical system, including me, all of us, we're failing to screen and prevent. Again, I'm not going to go over these again, but this is the same slide I presented earlier with the summary statistics, just showing that, FASD is still a really big problem worldwide. And there's no gold standard for screening or interventions, and there's really no one-size-fits-all approach. So like one thing to think about is that intervention needs for chronic alcoholics who are what we think of as people having several drinks every night are very different from the needs of episodic binge drinking, like we talk about with social or party drinking. I mean, in the States, and I think in a lot of places, people in their early 20s drink on the weekends, and they might have 4 or more drinks per occasion on the weekends. And if they do that just a couple of weekends a month, they're really putting the fetus at high risk there. And so the intervention you'd want to use for someone who's drinking really in a way that's socially acceptable in a lot of settings when you're not pregnant is very different from someone who has a real alcohol use disorder or alcohol dependence. And so screening would really ideally capture both groups, and I'll talk about that. And the focus is really between like preconception prevention, which focuses on education, versus screening and intra-pregnancy interventions. And so I'll talk briefly about those. So for preconception interventions, several trials have examined various educational prevention interventions, and all of them, the main beneficial effects were really in getting women to increase their use of effective contraception, so usually hormonal contraception in women who have risky drinking. And that's exciting and important. It's a little disappointing that we aren't as successful at getting people to decrease their drinking if they're in reproductive health age. At the same time, we don't want to stigmatize drinking. It's a behavior that serves a lot of important social functions in a lot of cultures. And so the most important thing is ultimately to prevent prenatal alcohol exposure. The methods for these include one-session conversations, interactive text messages or web learning, and also comprehensive educational platforms about reproductive health. So in terms of screening, I just posted kind of a picture here of most of the more commonly used screening tools. And although a lot of them are focused on alcohol dependence, I think that's not necessarily where we want to put our efforts, because you want to catch people who are engaging in risky drinking, even if they're not having alcohol dependence. And so I'll touch on just 2 of these, the Audit C and the TACE, which both take less than 2 minutes to administer. For the Audit C, you just ask, how often did you have a drink containing alcohol in the past year? How many drinks did you have on a typical day when you were drinking in the past year? And how often did you have 6 or more drinks on one occasion in the past year? And if there's a score of 3 or more, it indicates risk. And so that would identify a woman in the antenatal clinic where you would really want to hone in on intervention from there. The TACE is a little simpler. They just have to answer yes to 2 or more of these questions. How many drinks does it take to make you feel high? Less than or equal to 2 or more than 2? How many have people annoyed you by criticizing your drinking? Have you felt you ought to cut down on your drinking? And have you ever had a drink first thing in the morning to steady your nerves or to get rid of a hangover? And what's interesting about this one is I think although this does capture risky drinking, when you compare it to the Audit C, this is really getting at more symptoms of alcohol dependence and tolerance. And so I would say that this would probably lose some women who are just having kind of casual social drinking on the weekends. As far as screening best practices go, it's pretty clear that unmedicalizing or demedicalizing screening is important. So we know that when a doctor or the nurse gives the questionnaire, people can be intimidated and not answer as honestly. So social workers or psychologists are much better, of course, or, and community health workers. Of course, that's not always feasible in most settings. And it's better if the questions are part of a larger health screen rather than saying to someone, with like a stern voice, like, we're going to ask you about your alcohol consumption now. It's maybe better received and less stigmatized if it's couched in broader questions about health. And of course, then you still want to keep things short because you want to keep people's attention. And a very interesting thing that's been repeated in a number of studies is that a self-administered questionnaire followed by discussion does seem to be more effective. So what people will often do is hand someone a paper version of the questionnaire and ask them to fill it out kind of privately while they're in the waiting room. And then when they meet with the provider, they'll pull that out and go over the answers. And it is interesting that people are kind of more likely to be honest on paper than they are when someone's kind of staring at them. I think it takes away some of the bias that stigma introduces. In terms of interventions, there are a few versions. There's the single brief intervention and referral to treatment, which is often abbreviated SBIRT, and that may be better for episodic social binge drinking. That's one that we all would love to work because it's not as resource intensive. Intensive case management is another one, which will probably be better for those with abuse or addiction. And that's where people are really enrolled in intensive intervention programs with multiple meetings. And in all of these motivational interviewing, where you really help people identify what their motivation is behind drinking to help tackle those things, does seem to be the gold standard and seems to prove success for all approaches. So there's one study that happened in Uganda, northern Uganda, that I thought I would just highlight. So it wasn't a randomized trial, but they did compare pregnant women who received an intervention to those who did not as it was rolled out. And interestingly, at baseline, 8.8% of women reported binge drinking, which I was pretty surprised to see that it was that high. The intervention was education focused and based on a needs assessment that they conducted in multiple communities in the area. And the baseline awareness was lacking. So they really identified that people needed an intervention. And then the intervention was rolled out by village health teams consisting of community workers. And they did two-pronged kind of approaches. They went to like village meetings and community meetings and tried to get the messages out that way. And they also did home-to-home visits. And they focused on women of reproductive age and pregnant women, but they also included family members. As we all know that, drinking is a very social activity. And so increasing awareness, not just of the person you're interested in, but the people that they spend time drinking with, would hopefully maximize success. And so in terms of results, communication messages were significantly associated with a reduced odds of binge drinking. So an odds ratio of 0.09 is a really remarkable effect size to me. There was a decreased odds of drinking frequently, so odds ratio of 0.75. They also had decreased odds of harmful alcohol use, increased odds of adequate knowledge in a knowledge screen. And then this intervention was less effective, however, among those with alcohol use disorder at baseline. So again, I think this kind of educational intervention is really exciting and could potentially really work for people who are just drinking socially at risky levels and just need more knowledge, but might be harder for people who have alcohol use disorders or alcohol dependence. And then we're almost through with time here on my section of the talk, but I wanted to just highlight some high-risk groups. So in the interest of time, I'm not showing you a lot of data here, but there are a number of studies that have shown that women over 30 who drink at the same levels as women under 30 are more likely to give birth to an affected child. Women with a prior affected child are also more likely to have an affected child after that. And that may be because that's identifying women at high genetic risk. And there's a lot of new focus on trying to identify genetic markers of vulnerability, which could help with counseling. And then women with poor nutrition do seem to have a higher risk to their fetus when they drink. And so I'll just show you some data here on iron, choline, gestational weight gain, and food security. There's a lot of data on this slide, so we'll just focus on this upper left-hand corner first. On the y-axis, you have the regression coefficient for the relation between average alcohol per day on growth. And on the x-axis, you have different growth measures. And what we did was we stratified the cohort between moms who had inadequate weight gain and those who had adequate weight gain per the WHO recommendations across pregnancy. And you can see that for at 12 months, the effects of alcohol on growth were much more severe among those with inadequate weight gain compared to those with adequate weight gain. Then we split the moms into tertiles based on how many kilojoules they were eating per day. And you can see that moms in the lower two tertiles versus the upper third had much stronger effects of alcohol and growth at birth and on head circumference at 12 months. And then when we honed in on specific nutrients based on animal models, there's a lot to show that alcohol disrupts iron homeostasis and that women with poor iron stores are particularly vulnerable. And there's also animal models to show that dietary choline intake may modify the effects of alcohol, particularly if you can increase dietary choline intake to very high levels, the fetus may be protected. And again, you see these effects where women with lower iron intake or lower choline intake have children who are more affected. And I should say we looked, these are 4 measures of nutrition that probably you would think would have a lot of overlap. So like the women who are taking in the least amount of iron are probably the women who are taking in the least number of kilojoules. But there was, and this is like a mouthful here, but there was a large degree of non-overlap in each of these graphs, which means that they're really showing effects of the specific nutritional measure in the mother rather than overlapping across each other. And so this is exciting to me because if you meet a woman who's been drinking for 20 weeks, if you can find ways to optimize her food security and nutrition, maybe we can undo some of the damage that's already been done and possibly decrease the damage that might be ongoing. So in summary, the prevalence of prenatal alcohol exposure and FASD are much higher than appreciated globally. There's no level of drinking that's safe, but binge drinking is far more risky. And preconception and intra-pregnancy education, screening, intervention programs are really desperately needed. And as you could see, like they're not that difficult. I mean, it's easy for anyone to say because putting anything into practice in a busy clinic is very hard, but we're not talking about very intensive screening time commitments. And then just keep in mind high-risk groups, particularly those women who are older and those with poor nutrition. And I will pause there and hand the mic over to Dr. Wamiti. And both from Dr. Wamiti and from the conversation at the end of the session, I'm really excited to hear on people's perspectives on kind of the local context of how this is affecting people in your areas. Thanks so much.
Thank you so much, Carter, for just going through that overview and helping us see the importance of screening and demedicalizing screening so that the caregivers who are at risk can be identified. So I'll just share my screen. All right, so on my end, I'm going to be looking at the developmental outcomes in fetal alcohol spectrum disorder, and as introduced earlier by the team, Susan Omiti, I'm a developmental pediatrician. And so this is the outline of my talk. I'll just go through an overview. I'll try not to duplicate what Kata went through and look at developmental outcomes across the lifespan, what we can do, and summarize that. Second. Okay. And so this has been covered, but just as a brief summary, prenatal exposure to alcohol will result to physical, cognitive, social, emotional, and behavioral disorders in children. And FASD is the diagnostic terminology that's used to describe the constellation of effects that we see. And so, as Kata has covered, is that there is variability in the features, and there's still research being done to see whether there's a genetic vulnerability to these children who, with even a small exposure, they do get FASD. And so the timing and amount is really unique to the characteristics of the mother and the child. And so I'll just briefly go through the CNS dysfunction that we see. And it's really important to note that prenatal exposure to alcohol affects all stages of brain development, from neurogenesis and all the way to myelination. And so work that's being done is that they've demonstrated that it causes disruption in the cell-cell interactions in the brain. It alters gene expression and oxidative stress. And so the abnormalities that we see is that you get reduced brain volume in the frontal lobe, the striatum, the caudate nucleus, thalamus, and cerebellum. And in these children, you'll find that there's a thinning of the corpus callosum and abnormal functioning of the amygdala. And so this is just a really basic diagram showing an effect, the prenatal alcohol-exposed brain versus the one that's not. And so you'll find that these children have microcephaly and a less developed brain, and the corpus callosum, whose function is to communicate motor, sensory, and cognitive information between the left and right hemisphere, gets affected. And these are children who will result in having educational issues just because of problems retrieving information, attention, memory, problem solving. And then even for the motor aspects and even the cognitive, when the cerebellum is affected, you'll find that they have difficulty with fine motor skills, controlling movement, maintaining movement, but the way different parts of the brain are affected, we still don't know in terms of the exposure, the amount, and versus those who have genetic vulnerabilities causing this dysfunction that we see. And so when you look at the neurodevelopmental domains that are affected, it's really quite wide. As I mentioned before, they have difficulty with their motor skills, cognition, language, memory, attention, executive function, adaptive skills, and even the social emotional communication issues that they have that Kat had mentioned, that they can almost look like they have autism. And it's really important to tease out what's going on with that child. And they really have difficulties with controlling their impulses and emotional dysregulation. Why this is important is that whenever you're looking at the diagnostic criteria, there are those who have FASD with sentinel facial features. So you can see even across the different races, it's especially for the African child, it can be a child that's easy to miss. And University of Washington have the different measures that they and the different, when you look at the philtrum and the size of the upper lip, they have those that are for our end of things are sub-Saharan Africa and for other different ethnicities. And for diagnostic criteria 1, this is based on the Canadian guidelines. There are those who will have the 3 sentinel facial features in terms of the short palpable features. They have the smooth philtrum and the thin upper lip. And then there's a prenatal alcohol exposure that's been confirmed, either a mother who's been seen drinking or has been in trouble with the law. And then there are those who are known, whether they've been drinking or not, but the children have these sentinel facial features. And then it's important that they have impairments in 3 of or more of the identified neurodevelopmental domains that I went through. And this we can see in infants and young children and evidence of microcephaly. So the ones that are easy to miss are those who are under diagnostic criteria 2. And Kata went through that. These are the FASD without sentinel facial features. However, the neurodevelopmental domains are impaired, and you still have 3 domains that are impaired, as I described before. However, for this criteria, you have to have confirmation of prenatal alcohol exposure, not unknown like the first criteria. So it's really important to go through the different screening tools that Kata went through, especially for those who are at risk, and those who are just social drinkers are easy to miss. And so why is it important to learn about FASD? The issue with this and the reason why we need to prevent it is that it has lifelong implication and can last a lifetime. There is no cure for fetal alcohol spectrum disorders. However, research has shown that early identification and early intervention can really improve a child's development. So I really want to focus my talk in enabling you as clinicians to be able to identify these children so that we can intervene early for them so that we can get better outcomes. And so let's talk about the neonate, and I'll take a developmental perspective, that's okay. So this baby who's born, you'll find that if you're unaware of the history from the mom, it's important to do a proper physical examination. For those who are not, you've done your septic screening and you've evaluated for everything else. However, you're seeing this child is irritable, there's reduced arousal, there's reduced muscle tone, the abnormal reflexes. And so there are differentials that come with other genetic disorders, but it's really important to keep in mind about prenatal exposure to alcohol. And then the alcohol-related birth defects that I'll just quickly go through, that it's really important that those who you suspect, it's important to get an echo done. These are children who are at risk for different septal defects. They can get conotruncal heart defects, so it's important to get a cardiologist involved in the beginning. You really have to do a good physical exam because they have skeletal issues where you can get radioulnar synostosis, you can get contractures, scoliosis. And so it's important that you do a good physical exam targeting the musculoskeletal system. Doing renal ultrasound is important because you'll get the children who get kidney and renal malformations. I've had a patient who had a genesis of kidneys, and this a mom who had come in when she had already drank alcohol as she was pushing her baby. So that one was a baby who we were able to, didn't have sentinel features, but were able to do the appropriate tests, and we did find that the child had renal anomalies. it's important to evaluate, have the ophthalmologist or the eye clinic have a look at to see whether they have any retinal vascular abnormalities. They get optic nerve hypoplasia, strabismus, and even these children are at risk for conductive and neurosensory hearing loss. And so these are evaluations that have to be done so that we can intervene early by the specialists involved. And so let's look at infant development. So this is a child who are less than 1 year of age, and they may have been missed during the delivery, but then this is a child who's coming to the clinic, you're doing your well baby visit as a nurse or as a pediatrician, you find the child has poor feeding, has growth failure, irritability, the mom is, they've tried sleep hygiene and they're having sleep difficulties, they're easily overstimulated and difficulty with attachment. And so for those children who were missed in the neonatal period, remember you have to look for those alcohol birth defects, as well as intervene early by making sure that, whether we're doing attachment therapy for these children or getting nutritional rehabilitation, it's a team effort to be able to identify and intervene. And then we'll go into the toddler. And so for toddlers, it's really hard to tease out what is the usual, we call them the terrible twos or the terrible threes, but it's really important to identify that there is an age-inappropriate difficulties in attention and impulsivity. It's really important to pay attention to what that parent is telling you. They're like, I've had other children, but something's different about this child, or my child is different from the neighbors. And so it's really important to take a good behavioral history, even for that toddler. You'll find, as we've mentioned before, there are difficulty with peers, social impairments, and really the behavioral challenges are the ones that are really stressing for the family. This is a child who can't be easily distracted when they get a tantrum, they're aggressive, they're pushing, they're hitting family members and other children in the neighborhood, and they really have poor emotional regulation. Again, hoping through this talk that these are children who alert you for you to do a good behavioral history and refer appropriately. And so for the primary school going children, the things that really come up are the academic challenges. And as we've gone through how it affects all stages of brain development, you'll find that these are children who are struggling with processing speed, memory. The parents are like, oh, no matter how many times I teach this child these basic math concepts, I think he's gotten it, but tomorrow we are back to the same. And so these are children who you really need to refer for education assessments. They have issues with visual spatial reasoning, use of pragmatic language, executive functioning skills are a problem for them. And even as we do see the patients, we find even when you do a literature review, you find greater than 50% of children who've been exposed to alcohol have ADHD. And so it's really important to tease out whether it's ADHD causing impairment or is it the hyperactivity and the impulsive symptoms that don't quite meet criteria. Either way, these are children who require intervention and support and to be referred appropriately. And again, the behavioral challenges come up with emotional dysregulation and getting into trouble in school and get a lot of difficulties that need to be flagged and addressed appropriately. So for adolescents, and Kata really mentioned this, is that there are a lot of struggles. You'll find they have difficulty with abstract reasoning, even challenges with time. There are children who can't keep time, can't stay focused, even dealing with money. We've been lucky that nowadays you can use M-Pesa and other ways of transacting with money, but where you actually have to use cash and you need to count to understand what change you need to give, and what change you expect back, they have a lot of difficulties there. They have difficulty with their peers just because of those social difficulties, engaging, disruptive behavior, and you'll find that some of them struggle with adaptive skills and need support with even learning how to. They'll find motor skills, you'll find that buttons are difficult, putting on shoes, just tying laces, self-care can, depending on what level of like FASD is a spectrum, but depending on the impairment, you really need to identify them early so we can intervene. And the mental health issues really, really need to be focused on. A child who has, they're very oppositional, or you're finding their conduct disorders, or they're anxious, they're depressed, they're bipolar. Our colleagues in psychiatry are really important to intervene early so that we don't get into any problems. And just because of the issues with memory and poor academic performance, you get a lot of self-esteem issues, dropping out of school. And if you drop out of school, it's really difficult to, whether you're dropping off at high school, dropping off at the university level, it really interferes with your employment opportunities, and that can lead to even other experimenting with even drugs, alcohol, just to take care of that emotional need and the shame that comes with dropping out of school. And so it's really important for those interventions to be carried out by referring early. And so what type of support we give? And it's really just because of how heterogeneous FSD is, it really depends on that individual and the patient who's in front of you. And so for those children who have difficulties with fine motor skills and adaptive functioning, whether it's dressing, feeding themselves, or toileting, it's really important that you get the occupational therapist involved. And occupational therapists are really good in terms of even the cognitive piece, in helping them with attention, focus, and supporting their organizational skills, especially in the school setting. It's really important to get them involved. For those who have language delays, our colleagues who are speech therapists come in terms of helping identify where the issues are. Is it your receptive language? Is it understanding the language itself? Is it the communication skills? Is it functional communication? And so that support needs to be involved early. And then our educators are really important, because nowadays you find they're really referring children back to the doctors. And so if an educator refers a patient to you as a clinician, whether you're a therapist or a doctor, you really need to come together and figure out where the gaps in this in their education. Is it the attention aspect? Is it the cognitive aspect? And we have even KISE able to do that. We have educational psychologists, we have special needs educators. So we have avenues of coming together as a team to get the people in the education supporting our patients and referring either to them and even them referring back to us. So behavioral interventions are important. We really, like I said, it's a spectrum. However, you have to figure out, what are we targeting? Is it a child who's struggling with self-regulation? Is it a child who's having issues with adaptive functioning or cognition? The intervention for children is that we have to build these skills. Remember, there is no cure, but we can build skills. We can teach the brain something, and that is through repetition and other things that I'm going to get into. And then we have to remember there are interventions for caregivers. These are caregivers who are very stressed out. They're being judged in terms of their parenting skills. People are thinking that they're not helping their children. And so it's really important to help that caregiver to interpret the behavior of that child and improve their parenting skills, so that it's not always resulting to the child being hit or punished severely by the parents because they don't understand their child. And so the different interventions, and I really like this one. It's called the zones of regulation. And this can be used for children and adolescents. And you can see the zones there. There's a green zone, a blue zone, a yellow zone, and a red zone. And what are the zones for? It's for children to identify their internal states with color mapping. And so we want, and remember, this is something when for us as adults we can use. So we all want to be in the green zone, where our internal state is calm, you're feeling happy, you're focused, you're relaxed. However, some of these children, just because of what has happened to their brain, you find there are those who, because of mental health issues, in the blue zone, where they're feeling sad, tired, they're lethargic. And what activities and what can we do to help them go back to the green zone? And so on the other side is the yellow zone, those who are starting to get agitated, they're frustrated, they're worried, they're excited. And we're trying to identify where you, so that you can, before you get to the red zone, where you're angry, throwing things out of control, mad, that you're able to self-regulate and take yourself back to yellow and then back to green. And so this can be used with even parents, where they're being able to identify, when is my child starting to get frustrated? It's almost like the traffic lights that are starting to blink. We're starting to blink in the yellow or the orange zone in our end of things. And then we're trying to make sure that the child gets that emotional control back to where they're calm and happy. And so it really teaches children and adolescents strategies that you're pairing it with strategies of how to calm themselves down, mindfulness thinking, whether it's breathing in and out, whether it is a countdown, when you identify that you've crossed over to different zones from the green. And really in helping parents to build that skill in their children, really takes a team effort. And so it's important to use this framework to help families identify that dysregulation and being able to self-regulate. They're really technology-based intervention. There's a lot of assistive technology that's out there to help children with special needs. And when you think about this generation, of course, those who are in the urban areas and even some in the rural areas, the children are really into video games and things that can be accessed on phone, of course, in a regulated manner. And so GoFar is a video game that has been developed to address self-regulation and to help children make connections between the event that's happened and how to improve that behavior. So the acronym FAR is focus and plan, act and reflect. And so this is intervention where the psychologist or the team is helping the child through this gaming device to learn how to focus on the attention of the work that needs to be done. Whether it's in your being unable to complete certain tasks, and how do we come up with an individualized plan for you to solve that problem? And then where is this plan being carried out? Is it at home? Is it in school? And then for a child to reflect, and it will work really well with adolescents who have no cognitive impairments, to look at how the plan worked. Is it working for me, or did I lose my cool? Did I not regulate myself better? And how do I make it better the next time, so that we're not just reprimanding. If a child falls, you help them get up again and reflect on their actions so that you can come up with a plan for tomorrow. And so those are game-based interventions. And then behavior interventions for caregivers. It's really important, and our psychologists are amazing at that in helping with parental psychoeducation. It's really important for the parent to realize this is a brain-based difficult behavior. It's not a child who is misbehaving out of their own will. And when a parent understands that difference, is that we've had this prenatal exposure, we're having these difficulties because your brain is wired differently, then it helps the parent to be able to change their parenting styles. And important to encourage them to have a structured home environment. Children thrive on routines. And so it's good to have a routine around bedtime, around waking up, around dinner time, break time, whatever timings, it's good to have that routine so that children can be able to adapt easily to that. It's important for a parent to use really simple language that's concrete and literal, and a lot of repetition and patience when you're trying to correct your child. And helping the parent understand, let's focus on the strength of the child. What is the child really doing well? And how can we keep praising them and helping that positive reinforcement so the child can feel, at least I'm getting something right. And that helps with their own self-esteem. In caregiver mental health, whenever a child is having difficulty, especially in behavioral issues, because of stigma and the shame of not being able, feeling incompetent and unable to help your child, we really need to get on board, whether it's psychologists, whether it's support groups where these parents can go just to hear another parent story of how they overcame a certain thing. And so caregiver mental health well-being is really important for those who are struggling with their children. And so I really like the WHO has released a caregiver skills training program. It's online. You just have to type in on Google WHO caregiver skills training. And what I like about it is that there's no specific diagnosis that's required. It's an e-learning course that takes about 8 hours, and it's designed for caregivers who have children between 2 and 9, and especially targeting towards those who have, the children have difficulties with communication and difficulties with social interaction. And you can see how FASD children can fall under this. And what WHO has done is that they're showing caregivers opportunities to teach something, opportunities in everyday home routines, whether you're bathing, feeding, outside looking at flowers. It's about building their children's communication. How do you name something for a child? How do you use words to help them express their emotions instead of the child expressing themselves physically by pushing and kicking? And it really helps, gives parents ideas on different activities to promote positive behavior and how to improve daily living skills. And it also addresses caregiver overall well-being. So for those who are in resource poor settings, this is a caregiver skills training program that you can easily find online that you can share with the families. And so for our classroom interventions, it's really important to help parents understand that your child needs an individualized education plan. And you find that sometimes if caregivers feel a bit of shame that their child is a little different, you have to really explain that these IEPs, as they're called, helps a child to get accommodations. And the beauty about the Ministry of Education is that you can get those assessments done at the Kenya Institute of Special Education so that the school is given a plan for this child. This child's education needs to be structured, it needs to be predictable, you have to prepare them ahead of time. Can you give simplified directions to that individual child? Can you repeat with instructions with patience and care without judging? And how do you reduce distraction in the classroom? Maybe have a child sit right next to teacher at the front so they can't get distracted with what's going on at the back. And those are simple solutions that can be tailored and help the teacher support this child in the classroom setting. So a lot of people ask, are there medications specific for FASD? Unfortunately, they are not. And this is just because of the heterogeneity of the presentation. So the children will come in with different things. Some children will have no ADHD symptoms, but they're struggling with emotional regulation. There are those who have cognitive impairment. So really, it's about those symptoms that are causing impairment. So there's a lot of work being done to try and identify which stimulants are helpful for FASD children. And remember, with a stimulant, you always start with the lowest dose, and we always say, please talk with the specialists to figure out what behavior we're targeting. Is it the hyperactivity? Is it poor impulse control? And then when you start something, it's good to always evaluate back and see, is it helping this child? And so there are there's a lot of work being done to try and figure out other aspects of medication is going to be helpful for this child or not. For those who have mental health issues, please liaison with your psychiatrist or your whoever who's taking care of mental health issues in your departments. There are those who get depressed, so you want to get antidepressants on board as well as cognitive behavior therapy. Same for those who have anxiety disorders. It's really important to work with your mental health teams to support these children and their families. So what factors are associated with better outcomes? Early diagnosis is important, early identification before the age of 6, so we can take advantage of neuroplasticity of the brain, and early intervention, whether it's in therapy, in education, social services that the parents require. Whenever you look at all the different therapies that a child may require, are there places where we can get funding? Are there community supports in your communities where a child can go in to be supported and not be judged because of what the parent did? How do we create nurturing and stable home environments? How do we support these families to be able to have that? Our social workers are really good in going into homes, our community health workers to go into those homes and to train those community health workers to identify these people and refer appropriately. And then our school environments, where our children are spending most of their days, need to be supportive, they need to be structured and have a predictable environment for them. And so in summary, you can see all the different things that alcohol does to children. The costs on disability in our region are not known. In other, there's some work that are estimating that if you want complete proper care for a child who has special needs, it's almost 300,000 shillings a month. Who has that kind of money? So what do? We really need to prevent the damage that alcohol does to the brain, to different organs, and really target on awareness. So September is FASD Awareness Month. I'm part of the East African Academy of Childhood Disabilities. We're really big in using this month where there's awareness to be able to have conversations about alcohol use in our community. And Kat has really given a really good overview of what we can do, trying to find maybe those community health workers to be able to do those screeners. How do we train them so that we can get good outcomes for our children? Thank you.
Thank you very much, Susan and Kata. This is really, really informative. Thank you very much. We have some questions in the chat box. I know you can find time and answer some, but Others, we can answer them live. We have one anonymous attendee who's asking, what's the relationship between FASD and increased incidence of autism? I know you had touched on it, Susan. And, how do you tell apart the ADHD, impulsivity, and the FASD? How do you tell these things apart? For me, I would add later in life, especially when you're using the diagnostic criteria too. How do you tell in a primary school going child or those ones who are older? How do you tell that this is alcohol syndrome and not any other disease?
Oh, sorry, I was trying to unmute myself. And so thank you for the question. So with regards to trying to differentiate autism and FASD, for me, I'd say you have to go through the diagnostic criteria that is autism spectrum disorder, because we do find children who have ASD and have been exposed to alcohol. And remember that it's a clinical criteria where you're looking at social communication deficits that are inappropriate for age, because we always look at the chronological age of the patient and what those social communication deficits are like. And are we having those restrictive, repetitive behaviors in autism? So you can have those social communication deficits and do not have those restrictive, repetitive behaviors that we see in autism spectrum disorder. And so it really is I'd recommend that you send your child to the specialist to be able to tease those out. We have standardized tests that we are able to administer to tease that out. And then it's the same with ADHD. So you find that ADHD also has a diagnostic criteria in the DSM-5. And there are those who do not quite, because remember, when you're talking about ADHD, we're looking at those symptoms and whether they are occurring in multiple settings. So it can't be that you're only getting ADHD in the home setting. However, when you do the different questionnaires in the school setting, that they don't quite meet criteria, and then there has to be an impairment. So where is the impairment? Is it in your relationship with your peers? Is the impairment in your academic functioning? Is the impairment with your relationship? So we have different questionnaires that we're able to tease that out. Even for those who do not meet ADHD diagnostic criteria, we don't leave them alone. We functionally take care of the things that are causing impairment. So in development, we're really keen about functional support. So are you having difficulties with your language? Let's support that. Are you having difficulties with your adaptive skills? Let's support that. Because you'll find that a lot of these neurodevelopmental conditions really have the same functional impairments. And so we're really big on helping improve function as per the WHO ICF framework, as compared to zoning in just the diagnostic label, so to speak. And I think the other question was with regards to those who have FASD without the sentinel features. So one of the things that I talked about is those neurodevelopmental domains that are affected. So they're ideally, you're supposed to have 3 affected domains with regards to whether it's your adaptive skills or your social communication skills or your memory. So those are aspects where the specialist can help tease out those. And then what's important is that you have to have confirmation of prenatal alcohol exposure. And so, and that's always difficult because in our setting, people don't own up to drinking alcohol when they're pregnant. And so sometimes I find clever way of asking, before you found out you're pregnant, were you taking alcohol? And they're like, yeah, before I found out I was pregnant, I was drinking. So it's a way of asking in a non-judgmental way whether there's been some prenatal exposure. Thank you.
Thank you very much, Susan. Kata, we have 3 questions for you, mostly on epidemiology and the frequency of ingesting alcohol during pregnancy. So Timothy is asking if a mom used to binge drink, whether this would affect a child. So maybe you can share some articles or data that you've come across in the literature search. If this mom has been drinking alcohol and gives birth, will that child become addicted to alcohol? And anonymous attendee is also asking, in the Catholics where you take a wine during the Holy Communion, is that dangerous? And if she's spreading, is that dangerous? And then lastly, on the epidemiology of bizarre behavior, like in Kenya, we have people from Kakamega, from Meru. They are notoriously known for being very aggressive and angry. Can you say these people suffer from pediatric alcohol spectrum disorder?
I can probably comment on the first two questions. One is that, unlike opiates, a baby born after prenatal alcohol exposure does not show signs of alcohol dependence, even if the mother was very alcohol dependent. So that's one kind of silver lining there. And then, but as Dr. Wamiti pointed out, they can have a whole host of other long-term problems that are certainly worse than alcohol dependence. As far as the Holy Communion wine, like as much as I showed that graph showing that the effects of alcohol on development are linear. If there's one of the slides I showed is if the dose per occasion is very low, then that effect is pretty flat and probably not present. So I think a sip of wine at communion it would be hard for me to imagine that causing any appreciable danger. And then as far as breastfeeding goes, this is kind of an interesting question right now that different groups are publishing conflicting data on. We know that the level of alcohol in breast milk, it matches the mother's blood alcohol level. So if you think about a woman having like a pretty strong drink of like vodka or gin, right? What ends up in the breast milk is not the strength of that drink, but rather the amount of alcohol that's left in the blood after she's metabolized the alcohol in her liver. So the dose of alcohol in the breast milk is quite small. However, the baby only weighs 3.4 kilos, right? And the mom weighs, much more than that. So when you think about kind of dose per kilo, it is still like a much bigger dose for the baby than it is for the mother. And so people just have not really been able to tease out whether there are negative effects. And I think some of the methodological problems are that in studies like the ones that I do, where women are drinking very heavily during pregnancy, they're often drinking heavily after the baby's born too. And a lot of our control women who don't drink, they didn't drink at all. It wasn't just that they were pregnant, but in the community I work with in South Africa, people tend to either drink a lot or not at all, particularly I think because a lot of people have seen the negative effects of alcohol throughout their community. They kind of make a decision we're a family that doesn't drink. And so we don't have enough variability in pre versus postnatal alcohol exposure to answer that question definitively ourselves. And then I think what you find in studies in the United States is that people who drink more socially generally have money because alcohol is expensive. And so women drinking and breastfeeding at the same time postnatally, when you try to do those studies, the confounding variables of having more money and therefore their kids having access to better education, those things are really hard to tease out. And so I think I think this idea, I have a friend who's an obstetrician who says that they used to tell people that, if you're sober enough to breastfeed, it's safe for the baby. I think that's a little too laid back. I think the idea of pumping and dumping milk after a binge drinking episode is probably the safest route. But again, we're not talking about major problems for the brain of the baby in the way that you have with prenatal alcohol exposure, where the alcohol is literally going right to the brain through the placenta. So that was quite a long answer, but I'll pause there. I can't speak to this question about the region in Kenya because I'm not familiar with that region, but maybe Dr. Wamiti has more of a perspective there.
I can't say anything about the region either. And so, of course, we all have our own temperaments that are innate, and so that's all I can say. I don't think it's because their parents drank. I mean, the mother drank. So yeah.
We'll probably have to get more data on this communities, There's several questions on the role of fathers, alcoholic fathers. What is the effect on the fetus?
I can speak a little bit to that too, and I'm interested if Dr. Wamiti has other opinions. But in the animal literature, if you really give the father, especially in rodents, really high doses of alcohol preconception, there you do see epigenetic changes on the methylation and acetylation of the genome in the sperm that ultimately create the offspring. And so you do see effects. They're certainly much milder than what you see if the mother's drinking throughout gestation, where like the fetus is exposed to alcohol while it's developing. But this idea that aberrant epigenetic marks can be passed down from a heavy drinking father intergenerationally does play out in animal models. In the human studies, I don't know that anybody's really been able to show anything convincing. And I'm not sure why, why the difference there. I think certainly the effect sizes are going to be smaller. One thing that, again, when we talk about confounding or confusing situations is that how much a woman drinks during pregnancy is often heavily influenced by how much her partner drinks. And we've had cases in South Africa where we've had women want to stop drinking, but their partners were very upset with them because drinking together was, an important activity in their relationship. So I think how you tease out the father's contribution and the mother's contribution is more complicated from a statistical standpoint, particularly if the effects are going to be on the smaller side. But so I would say the jury's still out on that question.
I agree with Kata, just because it's something I'm also interested in terms of even for toxic stress in fathers and the cortisol, and you see in the animal models that you can find like those 3-generation epigenetic changes. And so it's just trying to figure out how to duplicate like from bench to the human models. It's difficult, but I always feel like there's some contribution, but how, when, I'm not sure about. But even for toxic stress in dads, we see that sorry, in animal models, we see those type of exposures and some effects.
Thank you. Probably on the last question is one of the anonymous attendees is asking that some women will consume a lot of alcohol in pregnancies and yet they give birth to normal babies. So probably, and is citing examples of one who actually is very knowledgeable and this child turned out to be a doctor. So does it differentially affect some children, and what are some of the protective things that would prevent a fetus from getting it and another one getting it?
This is a real area of interest for me in my research because we know there's a lot of variability in the severity of deficits in the child, even if a woman drinks the same amount. And so I think this is a really smart question, and I think it's on some level, it's great to say that no one should drink during pregnancy, but I think when we think about targeted interventions, we may be able to think both about how to identify women who are at highest risk for delivering a baby who's affected, but also we can think about what makes them high risk and think about how to intervene. And so that's why I'm really interested in whether optimizing mom's nutrition can help. It does look like that may work. It certainly helps in animal models. And then we can think about other things like a woman who's smaller than another woman will probably have a higher blood alcohol level than a woman who's larger if they drink the same amount. And so certainly size matters. Whether you eat during drinking episodes changes the way you metabolize alcohol. So there's a lot of variability also in blood alcohol concentration and alcohol metabolism. And then I think really Dr. Omiti commented on this, and I think it's really one of the cutting edge places research is moving right now is looking for like genetic markers of who's most vulnerable or who's least vulnerable, and thinking about how to use those genetic markers for screening, but also to how to think about what's happening physiologically. Like if there's a gene that has polymorphisms that are causing protection or vulnerability, what is that gene doing? And can we think about ways to capitalize on that knowledge to think about interventions, whether they're pharmaceutical or screening or otherwise?
Okay. And how long should a woman abstain from alcohol before she actually gets pregnant?
I think that goes back to the same question about the dad. Like you just don't want the fetus to be exposed to alcohol even in the pre-implantation phase, we know that alcohol does get to the fetus even before it implants. So I would say anyone who's trying to get pregnant at all, I would generally recommend abstaining fully, because you don't know when the pregnancy is actually going to happen, right? As far as whether like binge drinking, I get a lot of questions from people who say they went to like a few weddings in the summer and drank a lot and then got pregnant at the end of the summer, but they weren't drinking while they were pregnant. And I think that category falls into the same category as like the dad's epigenetic marks being passed down, or how Dr. Momiti was saying with like toxic stress. There may be effects there, but they're probably on the smaller side. I think focusing on things like optimizing your preconception nutrition, particularly with like folic acid and methyl donors, is probably more important. But I'm interested in Dr. Momiti's perspective there.
Yeah, I agree with you. It's difficult. Like for me, it's just abstain, but I can't even add more than that. I'm a bit biased just because I get to see the end result and the difficulties parents go through. It's a biased answer on my end.
So parting shot from each one of you. What's your part? Susan, parting shot from you.
Oh, sorry, I was trying to unmute myself. On my end of things, it's really like what Kata touched on, and forgive me, Kata, for coming in into your segment of things, is how do we support and identify these women? And then for us as clinicians, we need to really, for that child, especially the behavioral history that sometimes we forget to take. We're very good in taking the gross motor, how is the child sitting, walking, talking, but we don't take a behavioral history, because that's where some of these children are missed. And so for me, it's just to emphasize the behavioral history and early intervention and early referral. Thank you.
Parting shot.
Thanks. I really agree with that summary. And I think the other thing is just really thinking about awareness. I think there's so much stigma around behaviors that are considered risky in general. And, when someone feels like they're being asked about something because it might be damaging their fetus, they're always going to be maybe more hesitant to answer. And so how we balance kind of creating awareness and knowledge, but also keeping an open environment in the clinics so that we can identify people in need, is really always like a double-edged sword for me. And so I think just really driving home the global prevalence, and that this is a problem in really every society, but then also kind of, as Dr. Momiti was saying, how we support, we help people in a supportive manner rather than a stigmatizing manner is really important.
Thank you very much. This has certainly been very, very informative. I think for me, it has changed my clinical perspective and things to watch out for next time I come across pregnant women in the clinical setup. So really appreciate that the time you've taken to share with us this very informative webinar. So back to you, Nelson.
All right, thank you so much for the wonderful presentation and also for the engaging conversation afterward. Thank you to our participants for joining us today. We will be ending this week's sessions today, and we will be back from next week. So kindly check your emails and the usual platforms for information on our new upcoming webinars. Thank you and have a good night.
Good night. Thank you.
Right, thank you.
Bye.
Thanks, everyone.